Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. I welcome all of you in today's lecture on endocrine emergencies. And for those of you who don't know me, let me briefly introduce myself. My name is Mona Aboul-Seoud, and I am a professor at the endocrine unit of the Internal Medicine Department, Faculty of Medicine, Alexandria University. I see that we have a guest student among us, and I know that he doesn't speak any Arabic. For that reason, I will keep all discussions in English, right? If you don't mind. If the rest of you have any problems, just feel free to ask me. Okay? And before we start, let me put some ground rules. At all times, please keep your microphones muted to lessen the background noises and the echoes. And whoever has a question or wants to make a comment, please raise your hand so that I can allow you to unmute and talk. Okay? Of course, feel free to eat or drink during the session. We are all comfortably sitting in our homes. It's unlike the faculty. Okay? And whenever, if you feel like you want a break, just tell me. All right? Any comments, any suggestions, feel free to tell me. I'm open to suggestions. Any comments? Okay. So let me start sharing my screen with you. Please let me know once you see my slides. Okay? Can you see my slides now?
Yes, doctor.
Yes, doctor.
Okay, are they in slideshow or are they still small?
هما دلوقتي مش باينين.
مش باينين. A minute, I'll start sharing again. Can you see me type?
Yes.
All right. Are the slides visible now?
Yes, doctor.
Are they in slideshow?
Start.
Are they in slideshow?
Yes.
Okay, are they moving? Are they moving?
Yes.
Moving, yes.
Okay,
Yes,
great.
Yes, doctor.
Great. So our lecture today will include endocrine emergencies. And as you may know, these include pituitary apoplexy, myxedema coma, thyroid storm, acute hypocalcemia, acute hypercalcemia, acute adrenal insufficiency, and pheochromocytoma crisis. Of course, we should not forget the acute diabetic emergencies like hypoglycemia, diabetic ketoacidosis, hyperosmolar non-ketotic state, and lactic acidosis. But of course, I will not cover them in the endocrinology course because you are going to study them in details at the diabetes and metabolism unit. All right? So let us start by the pituitary apoplexy. Pituitary apoplexy actually results from hemorrhage into a pituitary adenoma. Fortunately, it is a rare disorder, but in the literature, it is reported to occur in 0.6% to 25% of cases of even treated adenoma. Okay? And of course, it will result in hypopituitarism. But the most serious amongst all hormone deficiencies is, of course, cortisol deficiency, because it can cause life-threatening hypotension. Okay? So what about the physiology? Actually, the precise pathophysiology remains uncertain, but it was found to be associated with trauma, hypertension, cardiac surgery, even dynamic pituitary tests and a large number of other conditions, including, of course, anticoagulant therapy. All right? Am I going too slow or too fast? Can you still hear me?
Yes, doctor.
Yes, doctor, we hear you.
Yes, doctor.
The pace is
Okay.
very good.
Okay, fine. So, the clinical picture, of course, the presentation, it ranges from relatively mild symptoms to the most severe, which is adrenal crisis or even coma or sudden death. Okay, when should we suspect pituitary apoplexy? When we have a triad of sudden severe headache, diplopia, and features of hypopituitarism, right? And of course, symptoms and signs, they may evolve over several hours or days. And like I said, they include sudden onset of severe headache. And sometimes the patient, they say it's the worst headache that I have ever experienced in my life. Visual field effects, including visual loss, nausea, vomiting, focal neurological deficit, altered conscious level, confusion, and even coma, together with shock, right? So this clinical picture you should never miss. And of course, the differential diagnosis includes subarachnoid hemorrhage and bacterial meningitis. So in that case, imaging of the brain, and of course, if you suspect pituitary apoplexy, you need not only to do imaging of the brain, but you need to do the cuts pertinent to the sella turcica. Because if you write in your request CT or MRI brain, they will do on the brain. They will exclude the cuts showing the sella turcica. All right. But if you suspect a pituitary problem, then you need to write in your request CT or MRI sella turcica. All right. So what about the treatment? Here, treatment is, of course, you need to support your patient with close observation of the vital functions, with blood glucose monitoring every 1 to 2 hours. And of course, you need to treat cardiovascular collapse. How? By giving hydrocortisone in a stress dose, which is 100 milligrams intravenously every 6 hours in normal saline, right? And of course, like I mentioned earlier, it is highly probable for other pituitary hormone deficiencies to be manifest. So if you plan to give thyroxine, then you must first give glucocorticoids and then you give thyroxine. Why? In order to avoid exacerbation of the cardiovascular collapse after correction of the metabolic rate. Is this particular part clear? Any doubts? Any problems?
Yeah.
All right.
It's clear, yeah, doctor.
Okay, fine. Early transsphenoidal surgery, especially when there are visual acuity or visual field abnormalities, can be also done because in the literature it was reported that recovery is greater. However, some other studies have found that in patients in whom there is no visual deficit or the deficit is resolving spontaneously, early surgical intervention does not offer any improvement in outcomes in terms of final neuro-ophthalmological defects or endocrine deficiencies compared with conservative management. So it's actually for the clinician to judge, all right? And once the patients are stable, they will require, of course, full endocrine investigation to assess the requirement for hormone replacement therapy, and lifelong follow-up will be required. Okay? Any problems so far? Any problems?
No problem, doctor.
No,
All
doctor.
right. All right. Now we shift to myxedema coma. This is a very important endocrine emergency because it is a medical emergency with high mortality rate. It can be defined as severe hypothyroidism with depressed mental status, hypothermia, and reduced function of the other organs. So early diagnosis of myxedema coma is very important. Actually, the term myxedema, it means puffiness of the limbs and of the face, and it's usually due to abnormal deposition of mucin in the skin and these tissues. Okay? So The clues to myxedema coma are previous history of thyroid surgery or administration of radioactive iodine, which in the long run causes hypothyroidism, or poor compliance to treatment with thyroid hormone. You have a patient who gives a history of hypothyroidism, but the patient is not properly compliant to thyroid hormone replacement therapy. Okay? And the clinical features are very obvious. A depressed mental state, like I mentioned, bradycardia, hypothermia, hypotension, and it has a prognostic significance actually, and type 2 respiratory failure, which means that the oxygen saturation is reduced and there is CO2 retention, right? This reminds me actually of a patient that I have seen during my residency. She was a female patient. She was 60 years old. She was brought in a wheelchair. Her daughter brought her in a wheelchair to the emergency department, and the patient was edematous all over. She was pale and puffy, okay? And she was sleeping. She put her head on her chest like that, and she was sleeping. She was brought in, by the way, she had abdominal distension. She was brought in for ascites for investigation, right? So I asked the daughter, what is wrong with your mother? She's sick, like you can see. Yes, what is wrong with her? She's sleeping all the time like that. What else? She said she doesn't move. If she sleeps on her right side, she will keep on sleeping on her right side the whole night without turning. And if she's sitting on a sofa, she will sit like a statue. She will never move. Okay? What else? So I tried talking to the patient. So Ismek Eya Hagga, what's your name? The daughter immediately told me, no, raise your voice, please. My mother doesn't hear properly. Oh, since when? She told me ever since she got sick like that. Okay? Okay, so I put my mouth inside the patient's ear. Ismek Eya Hagga, what's your name? And then the patient took a very long time responding. She was sleeping, like that. Imagine you are in deeply asleep and somebody wakes you up. How would you feel? She was disoriented and she wasn't even looking at me. She was looking anywhere else, somewhere else. And then the response time, take care. After maybe 5 minutes, she told me, listen to the voice, Zainab. And then she fell asleep again. So I noticed the voice. The voice was really very hoarse and deep. So I asked the daughter, is that the normal voice of your mother? She told me, no, of course not. But what happened to her voice? She told me ever since she got sick, her voice became deep and hoarse like that. All right. So I started examining the patient. Actually, she was very cold all over, not only the extremities. All her body was like a piece of ice. And then the pulse was like 45. She had severe bradycardia. The blood pressure was very low. And the temperature, she had hypothermia. All right. So remember, depressed mental state, bradycardia, hypothermia, and hypotension. And it turns out this lady was severely hypothyroid, and her daughter did well to bring her into the emergency, because if she had waited for another day or two at home, her mother would have gone into myxedema coma, and myxedema coma has a very high mortality rate. Actually, I have seen 3 cases since 1991 till the present date. Unfortunately, all of them passed away, even though 2 of them were admitted to the intensive care unit, right? The mortality is very high, okay? So we have to have a high index of suspicion in order to diagnose myxedema coma, all right? So despite the name myxedema coma, patients usually present with reduced consciousness, like this Hagga Zainab, or confusion, again like Hagga Zainab, or even psychosis. So they may present to the psychiatrist. So a good physician would really know how to suspect myxedema coma, okay? Rather than with comatose state. Okay, so remember that. Regarding the investigations, hyponatremia is common and it's seen in at least half of the patients. So in any patient with a low serum sodium and a normal volume status, you should suspect hypothyroidism. And of course, hypoglycemia is another common feature. Okay? So you should withdraw blood for TSH, free T4, and cortisol. Why? Because sometimes these cases, I mean, the origin of the hypothyroidism of the case may be due to an autoimmune disease. And you know that autoimmune diseases, they can be associated with each other. So a patient with, for instance, Hashimoto's thyroiditis can also have Addison's disease, right? So in any case, you need to withdraw cortisol as well. And if possible, only if possible, a short synactin test should be considered as coexisting hypoadrenalism is a possibility. And particularly so in secondary hypothyroidism due to a pituitary cause, right? Okay. And when you doubt the patient, the diagnosis, you should initiate treatment as quickly as possible. And it is preferable to combine T4 and T3. Why? Because who can tell me why? Who can tell me why? Why should we combine both T4 and T3? Can you still hear me?
Yes, doc.
So
لأن T4 T3 بيبقى جاي من conversion بتاع T4 T3
مش سامعة. Can
يبقى
you
موجود في
repeat, please? Can you repeat, please?
shorter duration of action and an increased efficacy compared to T4.
Yes, actually the normal thyroid in all of us secretes 80% T4, right? And 20% T3. Actually, the active hormone is which one? It's T3, right? So the T4 has to be converted peripherally in the peripheral tissues into T3 by 5-deiodinase enzyme, right? So in cases of myxedema, coma, or in general in cases of hypothyroidism, everything is slowed down, right? So the rate of conversion of T4 into active T3 is very much delayed. So it's better to give the active hormone, all right? Okay, but unfortunately here in Egypt, we don't have T3 preparations, okay? So, but we are forced to give T4. And of course, the dose of T4 is very high. It's between 200 and 400 micrograms per day, and preferably it should be given intravenously. But here in Egypt, we don't have intravenous T4 preparations again. Okay, and the dose of T3 is 10 micrograms 3 times a day intravenously. But as I mentioned, we don't have T3 preparations. And of course, the young, obese, and those with less likely cardiac risk should receive a higher dose than their counterparts. Okay? So maybe because here in Egypt we don't have the T3 preparations, the parental ones, maybe the mortality rate was very high. And you need to give a steroid cover in the form of hydrocortisone, 100 milligrams every 8 hours, until you have excluded hypoadrenalism. Okay? And of course, you need to do supportive treatment by correcting hypothermia, by careful warming of the patient, by correcting bradycardia, hypotension, by supporting the blood pressure and the respiration, and correcting hyponatremia. And of course, this supportive treatment needs to include treating the underlying disease. Okay, what brought the patient or what caused the myxedema coma to occur. Okay, and of course the prognosis, like I mentioned, it's very poor. In the literature, it's mentioned that around a third of myxedema coma patients die because of this myxedema coma in spite of aggressive treatment with thyroid hormone replacement therapy and supportive care. And as I mentioned, the 3 cases that I have seen since 1991, all of them unfortunately passed away. And all of them were ladies in their late 60s. All right? Any problems so far?
No problem.
Okay. Now let's shift to thyroid storm, quite the opposite. The precipitating events. Here, of course, the patient has an underlying hyperthyroidism. But what precipitates thyroid storm is any of the following, namely surgery. For instance, if the patient has goiter with hyperthyroidism and the patient is not properly controlled medically before sending her or him to surgery, then surgery can precipitate thyroid storm, sepsis, burns, diabetic ketoacidosis, a cardiovascular accident, for example, like myocardial infarction, or even parturition, status epilepticus, radioactive iodine treatment, or iodinated contrast material. This is very important. You will notice that whenever a patient goes to a radiology center to do an imaging study with the use of radioactive iodine, they in the history, they ask the patient, do you suffer from any thyroid illness because of this? Because hyperthyroid patients who are not properly controlled, they shouldn't receive iodinated contrast material, okay? Because they can potentially precipitate thyroid storm. Very important to remember, right? Actually, you need to know that thyroxine overdose does not cause thyroid storm. What causes thyroid storm? Actually, the pathogenesis is still unclear, but these factors may be implied, like acute discharge of T4 and T3 from the thyroid gland. For instance, if a patient who has hyperthyroidism and is still not properly controlled medically, and you decide to send the patient for radioactive iodine therapy, some patients, they can develop thyroid storm. This is why you need to control them medically properly before sending for radioactive iodine therapy, or inhibition of T4 or T3 to binding globulin, right? So what about the clinical features? They are usually of thyrotoxicosis, but they are more severe. So there is fever, okay, low-grade fever, 38.5, like that, tachycardia out of proportion to fever, confusion, agitation, again, nausea and vomiting, hypertension, and even congestive heart failure, right? The investigations, of course, you need to have a high index of suspicion. So you need to check the thyroid function tests. You will find decreased TSH with increased T3 and T4. You will find increased alanine transaminase, increased alkaline phosphatase, and increased bilirubin. Okay, and actually we have seen a case he was a male patient with coming with Graves' disease, and he had severe hyperthyroidism with elevated transaminases and elevated alkaline phosphatase and increased bilirubin. And at that time, the patient was somehow, we thought that the patient could have side effects from the antithyroid medications, okay? But we need to put into consideration that he might have been starting a thyroid storm, right? We need to put that in the back of our mind, right? And the treatment principles, they depend on decreasing production and release of thyroid hormones, blocking the effects of circulating T4 and T3, and dealing with the underlying precipitants. Okay, so let's discuss one by one. So to block thyroid hormone synthesis, we can use intravenous methimazole. Of course, as far as I know, we don't have it here in Egypt, okay? If you can find it, you give 20 milligrams every 4 to 6 hours until the patient is able to take oral carbimazole. In that case, you give 30 milligrams twice daily. This is a rather big dose. Or you give propyl thiouracil 200 milligrams every 4 hours, either orally or by nasogastric tube, okay, because it will block the T4 to T3 conversion. And both drugs can be given also by rectum, per rectum, by retention enema, okay? They are absorbed very quickly. And you can give also to block conversion of T4 to T3, you can give Lugol's iodine. You can give 0.3 milliliters diluted to 50 milliliters every 8 hours, given orally or by nasogastric tube for 5 days. You cannot give it for a longer time because, of course, the escape will occur. Okay. In the past, we used to have sodium iodide that could be given intravenously, but nowadays it's no longer available, right? And if patients are allergic to iodine, you can use instead lithium carbonate, 300 milligrams every 6 hours. Okay, why? Because one of the side effects of lithium is that it produces hypothyroidism because it blocks the conversion of T4 to T3. So actually we use the side effect of the drug in order to treat thyroid storm. And actually the patient I told you about was treated by lithium carbonate in this dose. And of course you need to monitor the lithium level until a therapeutic dose of 1 millimole per liter is attained. But unfortunately, here in Egypt, as far as I know, we cannot measure the lithium level. But you can also give intravenous corticosteroids, either dexamethasone 4 milligrams 4 times daily, which is a rather big dose, or hydrocortisone 100 milligrams 4 times daily as well. Okay? And of course, if there are no contraindications to beta blockers, who can tell me the contraindications to beta blockers? Some of them. Who can tell me what are some of the indications, contraindications of beta blockers? Who can tell me?
Bradycardia.
Sorry?
Bradycardia, doctor.
Bradycardia. What is more important?
Bronchial.
Asthma.
Exactly. Yes, of course, bronchial asthma. Right. Okay. Okay. What other contraindications? Can you still hear me?
Given cautiously during pregnancy يا دكتور يعني مش
Yes, of course, because they can cause placental insufficiency, okay, and as well in peripheral vascular disease also. Okay, they are relatively contraindicated. Okay, so if there are no contraindications to beta blockers, then the choice is propranolol, and you give it in a large dose as well, 80 milligrams 3 times daily, either orally or by nasogastric tube, or you can give it intravenously in a dose of 1 milligram per minute until the pulse rate is 100 beats per minute. Usually in thyroid storm, there is severe tachycardia, right? So you give until the heart rate drops to 100 beats per minute. But if beta blockers are contraindicated, then the possible alternatives could include calcium channel blockers or even digoxin. But usually calcium channel blockers can do the job, right? And of course, you need to give supportive treatment in the form of vigorous fluid resuscitation, if appropriate, external cooling. Remember, the patient has fever, right? Paracetamol for pyrexia. And here you should never give salicylates. Why? Because they inhibit thyroid hormone binding, and so they can worsen the thyroid storm. Very important. Never give salicylates in suspected cases of thyroid storm. Instead, give paracetamol, all right? And of course, it's much better to manage a patient in an intensive care unit. If you don't have, then in an intermediate care unit, all right? Okay, any problems so far?
No problem.
All right. Am I going too fast? Am I going too fast?
No, doctor, it's okay.
All right. Now let's shift to acute hypocalcemia. What are the causes? Low PTH can be secondary to thyroid surgery if the parathyroids are removed by mistake, or sometimes the parathyroid glands, they are ectopic. I mean, they are embedded inside the thyroid gland. So the surgeon, while doing thyroidectomy, he can remove the parathyroids together. Or parathyroid surgery, right? Or any neck surgery affecting the blood supply to the parathyroid glands. Or it can occur in autoimmune conditions, right? Or in underlying renal disease. But most commonly, it is due to vitamin D deficiency. Okay? And sometimes in hypocalcemia can be due to low magnesium levels. Remember that. As a result of what? Either diuretics, chronic diarrhea, or malabsorption. So always in cases of hypocalcemia, you need not only to measure the serum calcium, total and ionized, but you should also measure the serum magnesium level, like I will tell you in a bit. Okay? The clinical features, they are really very, you will be able to diagnose right away. The patient experiences paresthesia and numbness around the mouth and in the extremities, okay? And there is muscle spasm, particularly in the hands and feet, like carpopedal spasm, all right? And spasm of the laryngeal muscles may occur, leading to stridor and death. And tonic-clonic spasm may lead to convulsions. I don't like to call them convulsions. It's better to call them epileptiform fits. Why? Who can tell me the difference between the convulsions of epilepsy and the epileptiform fits of acute hypocalcemia? Who can tell me the difference? Is there any difference, or are they similar? Who can tell me?
I think doctor there are differences طبعا إنه the patient during the epileptiform activity of hypocalcemia, they do not lose consciousness, they do not bite their tongue, they do not hurt themselves.
Yes.
Unlike
Yes.
the convulsions.
Yes, excellent. What else? What else? What else? If it's grand mal epilepsy, there will be an aura. Most patients feel that they are going to experience a fit, right? And like you mentioned, Dr. Ala, during in epilepsy, the patient loses consciousness and he or she, they may injure themselves, right? And then what else? What is important is that in epilepsy, after the fit, the patient goes into deep sleep. But in epileptiform convulsions, after the fit, the patient returns back to regains consciousness immediately. And the patient can tell you, yes, I could hear you. You were shouting, you were calling my name, you brought me some water to drink, or you tried to put water on my face. Yani, the patient is conscious during the fit. But in epilepsy, the patient loses consciousness, right? And of course, the patient may also have incontinence of urine during the fit, but not during, during the convulsive, epileptic fit, but not during the epileptiform convulsion. So here, taking proper history from a patient with acute hypocalcemia is of utmost importance, because I will tell you, I've seen a case many years ago. He was a young boy. He was like 16 years old. He was short. He had a rounded face, and he had some skeletal abnormalities that I will tell you about in a minute. But he presented with what? With fits. Okay, so the parents brought him to Nariman Hospital, which is where the neurology department is. There they treated the patient as having epilepsy, so they gave him phenytoin, but the patient didn't improve. Time. I don't know how he came to the endocrine outpatient clinic. I don't remember what brought him to us. Still complaining of convulsions. When we asked about the history, the patient didn't have the criteria of the epileptic fit that I just mentioned. He didn't have an aura. He didn't lose consciousness during the fit. He didn't have injure himself. He didn't have any urinary incontinence. And after the fit was over, he was he regained consciousness spontaneously without falling into deep sleep. You see? So when we examined the patient, as I mentioned, he was short, he had a rounded face, and then when we looked, we made him make a fist like that. You see, make a fist like, can you see my hand? Make a fist, you will see that the fourth and fifth knuckles are visible. But this patient, he had short fourth and fifth metacarpal bones, so the knuckles were not visible. Instead of the knuckles, he had pits. Okay? So we diagnosed him right away as having pseudo hypoparathyroidism. All right? Okay? This is resistance to PTH, peripheral resistance to parathyroid hormone. Okay? I was telling you that because in order to differentiate the fits of chromal epilepsy from the epileptiform fits of acute hypocalcemia. Okay, so as not to lose track. This is how a patient with tetany would come. He or she, of course, would have carpal spasm, and the same would occur in the feet as well, pedal spasm, right? This reminds me of a patient that I have seen Bordeaux a long time ago. He was a male 40-something-year-old patient, a heavy smoker who had chronic bronchitis. And he came with acute exacerbation of his acute bronchitis. Chronic bronchitis type. We noticed that he had a tracheostomy in place. Okay, and he was bilaterally blind. Why? Because he had bilateral cataract. We asked him, why did you have the tracheostomy? He said, because several months ago, I was about to suffocate, so they brought me to ER, and there they put this tracheostomy, and ever since it had been in place. So still, why was he about to suffocate? Anyway, we didn't put in much consideration to that, but then when we started to examine the patient and we started measuring the blood pressure, he had Trousseau sign. Trousseau sign was positive. So retrograde, we checked for the Schwastek sign. It was also positive. So we started checking the serum calcium level of the patient. It was low, and the PTH was low. So it turns out that this patient had hypoparathyroidism, which led to acute hypocalcemia, which caused the stridor. Okay, so we controlled his hypocalcemia until he was normalized, and then we sent him to ophthalmology. He had the cataract surgery in one eye, and then I think 2 weeks later or 1 month later, he had cataract surgery in the other eye, and he started seeing again, and he was very happy. So always go to do root cause analysis for the patient's symptoms. Don't only treat symptomatic. Of course, stridor is an emergency, but don't just leave it at that. You have to know why stridor occurred. All right? Okay? So regarding the investigations, of course, you need to check the serum calcium, total and ionized. You will find it to be low. You will find high serum phosphate. And of course, if it's due to hypoparathyroidism, you will find a low PTH level. If it's due to vitamin D deficiency, you will find a low vitamin D level. And if it's due to chronic renal failure, you will find disturbed kidney function tests. And never forget to check the magnesium level. You will find that it is low, right? Treatment is actually based on the severity of symptoms and the level of hypocalcemia. So intravenous calcium replacement may be needed if calcium levels are below 7.5 milligrams per deciliter. And this is what we did for this patient that I was telling you about. And most patients with hypoparathyroidism would need, of course, lifelong treatment. Okay? So you need to give immediate intravenous injection of 20 milliliters. This would be 2 ampoules of 10% calcium gluconate, but you don't give them rapidly. No, the rate has to be very slow, 2 milliliters per minute. And it could be repeated every 4 hours. But in intractable cases, you can put 10 ampoules of 10% calcium gluconate in 1 liter of 5% dextrose, and you give them as an intravenous infusion every 4 hours. Okay? And once the serum calcium level starts to stabilize, more or less, you can continue giving oral calcium gluconate, but in a relatively high dose, 1.5 to 3 grams 3 times daily, with a high dose of vitamin D as well, 50,000 to 100,000 international units per day. But you can also give 125 dihydroxy vitamin D in a high dose as well, 4 micrograms per day. Okay. Of course, you need to check serum calcium every 3 months. And you need to maintain serum calcium between 8 and 9. And also you need to check for urinary calcium. All right. It's better to maintain serum calcium at the lower limit of normal in order to avoid that the patient goes into hypercalcemia. All right. Is it clear? And of course, if the cause is vitamin D deficiency, you give 50,000 units of vitamin D2 or D3 weekly for 6 to 8 weeks. And of course, in patients with hypocalcemia with magnesium deficiency, you should correct hypomagnesemia first. Okay? Any problems so far?
No, doctor.
All right. Let me just put my charger. Okay, can you still see my slides?
Yes, doctor.
Any problems so far?
No problem,
No
doctor.
problem, doctor.
All right. So now we will shift to acute hypercalcemia. Remember the case that Dr. Ahmed Abdelhamid presented today? We will present it again. And by the way, what you don't know is that Dr. Ahmed Abdelhamid did an ultrasound on the neck of the patient today, and he found a 1.5 centimeter parathyroid adenoma. What you need to know is that the normal parathyroid glands are not visualized on neck ultrasound. But once they become visible, this means that it is enlarged, right? And they consulted the colleagues from the head and neck surgery, and they said they would do neck surgery for the patient on Thursday, inshallah. Right? What is odd is that the parathyroid adenoma was not visualized on the system EB scan, because usually system EB scans are more sensitive to detect parathyroid adenomas, particularly ectopic parathyroid adenomas, than thyroid ultrasound. So I don't know why the parathyroid adenoma was not visible on system EB scan. So regarding the causes of acute hypercalcemia, over 90% of cases are due to primary hyperparathyroidism, okay, which is PTH mediated, and it's usually long-standing. But they can also be caused by malignancy, which is more severe and symptomatic, like our patient. Most probably the patient of today, since he has a rapid history, the history did not start 3 years ago like the resident mentioned. No, it started since August of this year. So like 4 months ago. And it's associated with severe weight loss, 27 kilograms in 3 months. This is significant. So it could be related to malignancy. I mean, in that case, not any type of malignancy, but in our patient, it could be due to a parathyroid carcinoma, right? Carcinoma, malignant parathyroid tumor, which is very rare. Or the other causes could be tertiary hyperparathyroidism due to end-stage renal disease, or as part of multiple endocrine neoplasias, or due to familial hypocalcuric hypercalcemia, like Dr. Temer mentioned today in his presentation. Okay? But you need to remember the non-PTH mediated causes of hypercalcemia, which include osteolytic bone metastasis, right? Here, if you measure the PTH, you will not find it to be elevated, but instead you need to measure something called PTH-related peptide. In that case, it will be elevated, okay? Or it can be due to increased calcitriol via extrarenal conversion, for example, in cases of sarcoidosis, right? Or increased vitamin D levels, again, due to hypervitaminosis D or over replacement with vitamin D, and chronic granulomatous diseases, again, like sarcoidosis, right? Okay. But remember, like drugs like thiazide diuretics, lithium, again, okay, and excessive vitamin A can also cause hypercalcemia. So you need to take proper drug history from the patient. Hyperthyroidism, acromegaly, and pheochromocytoma can also cause hypercalcemia, but it is usually mild, okay, never severe. What are the general manifestations of hypercalcemia? Weakness, easy fatigue, weight loss, generalized bone pain, renal colics, dry, scaly skin, and pruritus or itching. But these, you see, these are not specific. Yeah? Many other diseases can cause the same manifestations. But there are systemic manifestations of hypercalcemia, like, for instance, GIT manifestations, which include nausea, vomiting, dyspepsia, abdominal pain, constipation, and even chronic pancreatitis and calculi, right? The patient of today, he had his serum amylase and serum lipase measured, right? And never forget the neuropsychiatric manifestations of hypercalcemia in the form of proximal myopathy. This term proximal myopathy is encountered in many other endocrine diseases, like in Cushing's syndrome or disease, like in hypothyroidism, in hyperthyroidism, in acromegaly, all right? And peripheral sensory neuropathy, depression, poor concentration, and memory deficits. Okay, so such patients, patients with hypercalcemia, they may very easily present to the psychiatrist, right? Cardiovascular manifestations are also very important, and these include hypertension, short QT interval, like I'm going to show you in the ECG in a while. Skeletal manifestations are very important, like general aches and pains, osteoclastomas of the jaw, bone cysts, and brown tumors. I'm going to show you these. Pseudogout and chondrocalcinosis, and even pathological fractures. And the renal manifestations should not be forgotten, in the form of polyuria, polydipsia, renal calculi, and nephrocalcinosis, like the patient that we have seen today. All right. So this is the ECG. Can you see the pointer? This is the normal ECG, okay, the QT interval. It's 0.36 seconds, but here in a case of hypercalcemia, you see that the QT interval became short, 0.26. This is significant, okay? And this is the osteoclastoma of the jaw that I was telling you about. This is a CT of the skull in coronal cut like that, if you can still see my picture. All right. Let me show you the anatomy. This is of course, bone appears white. So this is the middle cranial fossa. This is the jaw. This is the nasal septum. And these are the nasal turbinates. Air appears black. So this is air in the nasal cavity. And this is the maxillary sinus. Okay. And here you see the jaw. The mandible is expanded with a brown tumor, and there are septi inside. You see? Can you see my cursor? Okay, so this is the typical osteoclastoma of the jaw, right? And these are the bone cysts. This is a plain X-ray of the left hand of a patient showing several bone cysts, like here, 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 and there. All right. And this is a plain X-ray of the pelvis, in particular of the left hip joint of the patient, showing, you see the arrow is pointing at an expanded bony lesion in the inferior pubic ramus. You see it has like attempts at new bone formation. So this is another area for an osteoclastoma or a brown tumor. Okay, so you will tell me, what is the difference between a brown tumor and a bone cyst? A bone cyst is an area devoid of structure, as if somebody has taken away the bone, all right? But here you can see that the inside the bone, at first the bone is expanded, and then inside there are like attempts at new bone formation, okay? And this new bone, of course, is not healthy. So this is why it is liable for pathological fractures, okay? And this is chondrocalcinosis. This is a plain X-ray of the knee joint. Normally, a cartilage appears black on X-ray, okay? Bone appears white. This is the femur, this is the tibia, while the cartilage, the menisci, they should appear black. But if you look closely, you will find a white line here, a white structure there, a white line here, a white line here, and here. So these white lines represent calcified cartilage inside the knee, chondrocalcinosis. Is it clear?
Yes, doctor.
Okay.
Yes.
Okay. And this is a plain X-ray of the left femur of a patient, showing what? You see there is a distal lesion here. It has a well-marginated with endosteal scalloping. If you look closely inside, you will find there is another different structures inside. Okay, so this is another brown tumor. And more proximally, the patient had a similar brown tumor, but he or she, I mean, they were unfortunate enough to have suffered a pathological fracture through this brown tumor. Okay. And this is the abdominal ultrasound showing multiple renal stones. You see, this is the kidney cut longitudinally like that. It's reniform or kidney shaped. You will find, you see the renal stones appear very bright, like white structures. And behind them, there is an acoustic shadow. The acoustic shadow is like, imagine you are walking in the sunshine under an umbrella. The sun rays will produce a shadow under the umbrella, right? The same occurs here. The ultrasound rays, they come from the anterior abdomen like that, and they normally they should pass through the different tissue planes until the posterior abdominal wall. But here they encounter the renal stone, which produces this acoustic shadow. Okay, and the other kidney shows the same again. Type, how does nephrocalcinosis look like? It looks like that. You see, this is another transabdominal ultrasound in longitudinally, cutting the kidney longitudinally. You will find pyramid-shaped hyperechoic structures at which the arrows are pointing with posterior acoustic shadows. Why? Because here the pyramids are calcified. There is calcium deposition inside the pyramids. But here, the calcium, you see the calcium is more dense and it is not in the pyramids, it's inside the pelvic calyceal system. Okay? Is it clear? Is the difference clear between the renal stone appearance and the nephrocalcinosis? Any problems? Can you still hear me?
Yes, doctor.
Okay.
Doctor, it's clear.
All right. Okay. Regarding investigations, we measure serum ionized calcium. It's usually preferred, particularly if there are abnormalities of the serum albumin or conditions like multiple myeloma are suspected. You will find, of course, the serum ionized calcium will be high, like the case of today, low serum inorganic phosphorus, and you will find elevated alkaline phosphatase. Okay, why is the alkaline phosphatase elevated? Who can tell me? Huh? Who can tell me?
It means because of bone mineralization.
Because of what? I didn't hear. Can you please repeat? Do you still hear me? Who was talking? Dr. Passant? Was it you?
No, but I think because of bone turnover.
Yes, can you explain more? What about bone turnover? Can you elaborate more on that?
There is increased ionized calcium, there is bone resorption, and
Yes.
there is bone mineralization.
Let me ask you the question in another way. Where does the alkaline phosphatase come from? From which cell in the bone?
Osteoclast.
No, it's not the osteoclast. It's the osteoblast, okay? So like you mentioned, Dr. Passant, there is high bone turnover. So the osteoclasts are very active and they eat the bone. They eat up the bone. And you know that there is homeostasis in the bone, right? In order to keep the bone mass constant or to avoid any decrease of the bone mass, the osteoblasts will become more active. So they will start producing more alkaline phosphatase. So this is the cause of high alkaline phosphatase. Is it clear?
Okay, thank you, doctor. Yes.
You're welcome. All right. And of course, like today's case, hypercalcemia. If you measure calcium in 24 hours urine, you will find it to be elevated, more than 350 in men and more than 250 in women. Okay. And of course, in cases of primary hyperparathyroidism, you will find elevated plasma PTH level. Right? But also in cases of secondary and in cases of tertiary hyperparathyroidism. Okay? Type, what about the treatment? Here, the goal of treatment is to lower hypercalcemia and to treat the underlying cause. So usually hypercalcemia less than 12 milligrams per deciliter is asymptomatic. In asymptomatic patients may not warrant immediate treatment. But initially, if you decide to treat, you give 0.9% saline to correct dehydration, but in a very large dose, like 4 to 8 liters every 24 hours. And of course, in patients who are at risk of fluid overload, you need to give furosemide in a big dose as well, 80 to 120 milligrams every 2 to 6 hours. And needless to say, you need to monitor urine output, serum magnesium, serum potassium, serum sodium, and if possible, also the CVP. Okay, particularly if the patient is elderly and you are afraid of hypervolemia, right? But in severe symptomatic hypercalcemia, you can give calcitonin at a dose of 4 international units per kilogram subcutaneously or intramuscularly twice daily, okay, for the first 2 days. It has immediate effects, but actually after these 2 days, tachyphylaxis may develop. This means that the patient will not respond any longer, all right? Type, what else can you give? Bisphosphonates. They are the most preferred agents for treating hypercalcemia, and they work by inhibiting osteoclastic activity. Okay, like we have pamidronate. It is given in a rather big dose, 60 to 90 milligrams intravenously over a relatively long time, 2 to 4 hours. But we don't have it in Egypt. The alternative would be zoledronic acid, 4 milligrams intravenously over 15 to 30 minutes. Okay. But of course, like mentioned today in today's meeting, you cannot give bisphosphonates if the kidney function is impaired. So the patient of today who had the serum calcium of 18, but the creatinine was 5.6, you cannot give these drugs, all right? Glucocorticoids, like also in big doses like prednisolone, 30 to 60 milligrams, they will usually reduce serum calcium concentrations within a few days by decreasing calcitriol production, particularly by if you have a chronic granulomatous condition like sarcoidosis. Glucocorticoids will decrease calcitriol by the activated mononuclear cells in the lung and lymph nodes, right? You can also give calcimimetic agents like cinacalcet to reduce serum calcium concentration in patients with severe hypercalcemia, and it is useful in hemodialysis patients. Actually, I have seen a patient who was in her late 70s who had a parathyroid adenoma, but she was a poor surgical candidate. She had a lot of other comorbidities, and so she refused the surgery, and the surgeons thought it would be problematic to submit her to surgical treatment. So she is taking cinacalcet, and her hypercalcemia is more or less under control, right? Any problem so far? You want to break? Are you still there?
Yes,
Yes.
doctor, no problem.
Yes, doctor.
Okay, don't fall asleep on me, huh?
No.
Okay. Now, let's shift to Addisonian crisis. The causes are varied, like undiagnosed Addison's disease in patients on steroid replacement with an intercurrent infection or acute stressful condition with failure to increase the steroid dose. You know that patients who have hypocorticism and they are taking glucocorticoid replacement therapy, you need to instruct them to increase, to double or even triple the dose of corticosteroids whenever they have any intercurrent infection or acute stressful situation. Okay? The rare causes would include bilateral adrenal infarction or hemorrhage, and secondary adrenal failure, which can present with hypoglycemia, right? The primary adrenal insufficiency can also occur due to autoimmune conditions like autoimmune adrenalitis, okay, or tuberculosis or metastasis. These we see, and you need to remember them. Or even drugs like antifungals, like ketoconazole, an important side effect of antifungal drugs. And we use the antifungal drugs for medical adrenalectomy in cases of Cushing syndrome to decrease serum cortisol level before you send the patient for surgery, right? So never forget, antifungals can cause primary adrenal insufficiency. Secondary adrenal insufficiency due to a pituitary pathology where there is only glucocorticoid deficiency without any mineralocorticoid deficiency, okay? So in cases of secondary adrenal insufficiency, usually adrenal crisis is rare, okay? But adrenal crisis, remember, adrenal crisis can also occur in patients who have abruptly stopped their steroid medication. For example, a case of any patient with, for instance, lupus nephritis. She was taking large doses of corticosteroids for several months, and then for some reason or another, she stopped her medication suddenly. In that case, the adrenals would be suppressed, so the patient would go into adrenal crisis. So here you need to take proper history from the patient again, okay? The clinical features are very important because they are usually non-specific. So you have to have a high index of suspicion because acute adrenal insufficiency is a potentially life-threatening emergency. So these clinical features include anorexia, nausea, vomiting, abdominal pain, fever, and general lethargy. You see, a lot of other conditions can cause these same features, right? So adrenal crisis should be considered in any patient who presents in a state of shock, even when there is no prior history of adrenal disease, particularly if there is coexisting unexplained severe hypoglycemia or hyponatremia. Very important, right? So you need to do investigations like serum electrolytes, sodium and potassium, cortisol, and ACTH, preferably before initiating steroid treatment, okay? And ideally, the diagnosis should be made by a short ACTH stimulation test. You know that in endocrinology, whatever is low, we stimulate. Whatever is high, we suppress, right? But there should be no reason to delay treatment in a very sick patient, because the patient may die. This is a life-threatening condition, remember, right? So how to treat? Initially, you resuscitate the patient with intravenous fluids by giving 2 to 3 liters of 0.9% saline. And of course, you after having taken a random blood sample for cortisol and ACTH, right? But if you plan to take a blood sample for ACTH, remember that this molecule is very fragile and the sample must be taken on ice, on editor, an editor tube and placed on ice, and it must reach the lab within 30 minutes in order not to be degraded, right? And in the lab, they should centrifugate it in a cooling centrifuge, all right? And after that, you give intravenous glucocorticoids, 100 milligrams hydrocortisone every 6 hours, okay? And you should give it right away. Don't wait until the short synactin test results are ready, okay? And although here in adrenal crisis, although the hypotension and electrolyte abnormalities are predominantly due to mineralocorticoid deficiency, replacement in acute adrenal crisis is not required, as sodium and volume replacement with 0.9% saline are sufficient. Okay? And of course, the precipitating causes of adrenal crisis need to be identified and treated properly. Okay? And once the patient is stabilized, the diagnosis can be confirmed by performing a short synactin test. Of course, a long synactin test may be required if ACTH level is equivocal in order to diagnose secondary adrenal failure. So how do we diagnose adrenal insufficiency? You take a basal sample for plasma cortisol and preferably also urinary free cortisol. Okay, and if you find them in the low normal range, you cannot exclude the diagnosis. However, if you have a basal cortisol value greater than 14.5 milligrams per deciliter, this invariably indicates an intact hypothalamic pituitary adrenal axis. Okay? And all patients suspected of having adrenal insufficiency should have an ACTH stimulation test. How is it done? The short synactin stimulation test involves taking a blood sample, basal blood sample, at time 0, okay? And then you give the patient either intramuscular or intravenous tetracoxactin or synactin in a dose of 250 milligrams. And then you take another blood sample after 30 minutes. A normal response would be a peak plasma cortisol of more than 20 milligrams per deciliter. Okay? So what about the long ACTH stimulation test? This involves giving a depot form or intravenous infusion of tetracoxactin for 24 to 48 hours. What is the importance of this test over the short synactin stimulation test? It has the ability to differentiate between primary and secondary hypoadrenalism. How is that? In all of us, we are normal, right? So in normal subjects, plasma cortisol at 4 hours are greater than 36 milligrams per deciliter. Beyond this time, so if you measure after after 1 day or after even 2 days, there is no further increase. This is in all of us, okay? But in patients with secondary hypoadrenalism, they show a delayed response with usually a much higher value after 1 day or 24 hours and after 2 days than at 4 hours. While in primary hypoadrenalism, there is no response at either time, okay? And in primary adrenal insufficiency, also the ACTH level will be disproportionately elevated in comparison to the plasma cortisol, all right? But in secondary hypoadrenalism, of course, ACTH level would be low or low normal, okay? Is that clear? Any problem so far?
No problem, doctor.
All right. And then you need to maintain glucocorticoid therapy by giving hydrocortisone 10 milligrams twice a day. Of course, trying to simulate the normal diurnal variation of cortisol secretion. Okay, so you give the big dose in the morning and a smaller dose in the evening. But in Egypt, we don't have hydrocortisone tablets, so you give the equivalent of prednisone or prednisolone. So you give 5 milligrams in the morning and 2.5 milligrams in the evening. Okay. Of course, in primary hypoadrenalism, you need to give mineralocorticoid replacement as well in the form of fludrocortisone in a dose ranging between 50 and 200 micrograms per day, according to the patient's symptoms and presence or absence of postural blood pressure. Okay, so how do you monitor adequacy of glucocorticoid dose? By simply the clinical well-being of the patient and restoration of normal but not excessive weight. Because mind you, all cases of hypoadrenalism, they have loss of weight, okay? And of course, normal cortisol levels during the day while on replacement hydrocortisone, okay? And how do you monitor the adequacy of fludrocortisone replacement? By restoration of serum electrolytes back to normal and by the blood pressure response to posture. Remember, patients with hypoadrenalism, they have postural hypotension, meaning that if you measure the blood pressure of the patient while he or she they are sitting, and then you ask the patient to stand for 2 minutes, okay, the blood pressure falls usually more than 10 millimeters mercury systolic after these 2 minutes of standing. And why do we have to wait for 2 minutes? In order to allow the sympathetic reflexes to act, okay? But in cases of adequate fludrocortisone replacement, this postural drop of blood pressure doesn't occur any longer. And of course, if you like, you can measure the plasma renin activity. You will find it returns back to normal. But usually we don't check that because it is expensive. Okay? Any problems so far?
No, doctor, it's clear.
All right. And of course, you need to give the patient advice about what they, abroad they carry a steroid card, like they put it in their wallet, or they wear it around the neck, or they as a bracelet, in order to where it is written, "I suffer from Addison's disease. In case of emergency, please contact," and then a phone number, right? You need also to give advice to your patient that in minor illness, like for example, upper respiratory tract infection, the patient needs to double the usual steroid dose until they are well. And then they can gradually reduce it to the normal dose, okay? But if the patients are not able to take the drugs orally, in that case, you need to admit the patient to the hospital for intravenous steroids, right? And of course, you can also give the patient an emergency hydrocortisone vial for emergency intramuscular use. The patient can give it to himself or the spouse or the relatives living with him or her at home. They can give it to him or her before going to the emergency department in order to save some extra time. All right? Very important. And of course, if the patient is planned for surgery, you need to do steroid cover. You need to give steroid cover in the form of intravenous 100 milligrams hydrocortisone at induction of surgery and 50 milligrams 3 times daily until the patient is fit to take the normal oral dose. Right? Any problems so far? Any problems?
No,
No,
Dr.
doctor, no
Clear.
problem.
Okay. The last topic we're going to discuss today is pheochromocytoma crisis, another very important topic. The term pheochromocytoma crisis is used when patients present with potentially life-threatening hemodynamic disturbances, either in the form of hypertensive crisis or cardiogenic or adrenergic shock. The mortality of a pheochromocytoma crisis is very high, around 85%. Okay. Actually, there is no arbitrary cut-off level of blood pressure at which hypertension becomes an emergency rather than an urgency. But the generally accepted limiting values are a systolic blood pressure of 220 millimeters mercury.
دكتور هو في لاج في السكرين مش عارفة عندي أنا بس ولا عند الكل؟
What about the rest of you? Can you see my slides? Can you see
Yes, doctor, it's clear. Yeah.
طيب يعني
sorry.
I think it's
Yes.
from your side. Who was
Your
talking?
net,
I don't.
my net. Percent. It's not my network.
Okay. Okay.
Okay, thank you. Sorry.
Can you see the slide now?
Yes, yes.
Okay,
It's better
fine.
now.
Okay. Okay. So as I mentioned, the generally accepted limiting values are systolic blood pressure of 220 millimeters mercury and a diastolic blood pressure of 120 millimeters mercury. Okay. What are the causes? They are varied. They can be, a pheochromocytoma crisis can be precipitated by straining, by exercise, even by pressure on the abdomen. I remember when I was a resident a long time ago, sorry, we had a patient. She was a female patient in her mid-40s. She was a nurse, okay? She had a pheochromocytoma and she was, for one reason or another, she went to Mansoura University to have the surgery, all right? But unfortunately, several years later, it recurred because you know that in 10% of cases, pheochromocytomas can be recurrent. So it recurred. So in order to show the spell or the pheochromocytoma attack to the students and to the house officers and the residents, we used to palpate her abdomen. Something very cruel to do, of course, but yani, in order to show them how a pheochromocytoma spell or attack looks like, okay? And drugs like anesthesia. So remember, whenever you send a pheochromocytoma patient for surgery to have the tumor removed, you have to pay particular attention that the patient has to be very meticulously controlled in terms of blood pressure and plasma volume in order not to elicit a pheochromocytoma spell during surgery, because whenever during surgery, even if it is laparoscopic, they manipulate the tumor tissue, okay? Manipulating the tumor tissue can elicit a pheochromocytoma spell as well. But not only that, but also anesthesia, induction of anesthesia itself, all right? Always remember that. So the clinical features are varied because a paroxysm or a spell can last for a few minutes up to several hours. And it can occur as often as several times a day or as yani, or less frequent, once a month or even less, okay? The classic triad of a pheochromocytoma spell is that of episodic headache, sweating, and tachycardia, all right? But you may find also a patient with sustained or paroxysmal hypertension, okay? And remember, around 10% of pheochromocytoma patients, they may have normal blood pressure, all right? But if the patient has this pheochromocytoma spell, the clinical features during that spell are profound sweating, marked tachycardia, pallor. Why pallor? Never flushing. Pallor. Why pallor? Who can tell me? Why?
Because of vasoconstriction.
Sorry?
Because of the vasoconstriction.
Yes, excellent. Because of peripheral vasoconstriction. Okay? Numbness, tingling, cold hands and feet, right? And regarding the investigations, usually we measure the fractionated metanephrines in plasma, okay, or the 24 hours urinary fractionated catecholamines and metanephrines according to whether the index of suspicion is high or low, right? And once you have biochemically confirmed that the metanephrines are high, in that case you need to do localization of the tumor by doing a computed a CT of the abdomen or an MRI of the adrenals, right? But in some cases, you need to do an MIBG scan. MIBG is short for methiodobenzyl guanidine scan, right? Because, you know, in 10% of cases of pheochromocytoma, they are extra adrenal. So you need to locate where the tumor is, right? So this is an axial CT. Axial means it's cut like that, transversely. Let me revise the anatomy, right? The patient is lying on the back like that. You can still see my hand. And this is posterior, this is anterior, this is right, this is left, because the patient, you're cutting the patient's abdomen like that, and you're looking from the feet of the patient to the inside of the abdomen. Okay, so again, what is white is bone, so this is the vertebra, and these are the ribs. Okay, this is the right side, so this is the liver, and this is the spleen. Okay, this is the right kidney, and this is the right adrenal, and all this huge structure, you see, heterogeneous structure, is a very large, partially vascular, because this patient was given intravenous contrast. You see the aorta, abdominal aorta, is bright because it has taken the intravenous contrast, and this is the celiac trunk here, and you see the portal tracts are also bright because they have taken up the contrast. So this mass is partially vascular. The areas that are relatively bright are vascular, and the darker areas are the necrotic parts. And most probably because it's large like that, and it's usually said that any adrenal mass larger than 5 centimeters is usually malignant. Okay? So this was the CT. This is the MRI. Okay? You will notice the difference between the CT and an MRI is what the MRI appears as if the image is blurred, okay? But the anatomy is still the same. This is posterior, and this is anterior, this is right, and this is left, okay? This is the vertebra. And here inside, you can see the spinal cord surrounded by CSF, okay? And this is the abdominal aorta. It appears signal void. Why? Because flowing blood gives no signal on MRI. And this is the right crus of the diaphragm. This is the left crus of the diaphragm. This is the liver, and this is the gallbladder. This is the left kidney, the spleen, okay? And this is a very large heterogeneous, again, mass, okay? It's large, you see, 3.3 by 3.5 by 4.5 centimeters, okay? The urologists, they usually prefer doing an MRI with an in-phase and out-phase in order to diagnose pre-operatively whether the pheochromocytoma is benign or malignant. Okay, it can be usually done by the in-phase, out-phase MRI. Okay. And this was the T1 weighted. How can we distinguish if it's a T1 weighted image or a T2 weighted image? By looking at the CSF. You see here the CSF appears black. So this is T1 weighted image. This is the same image. You see CSF here appears white. Okay. So this is a T2 weighted image. Okay. With the same findings. But here you find that the pheochromocytoma, the mass, has increased signal intensity on T2 weighted images. This is a particular characteristic of pheochromocytoma. Okay. And this is the MIBG scan, a whole body scan where you want to localize, but this is the anterior view and this is the posterior view. This case is easy. Why? Because there is concentration of this radio tracer here in the area of the left upper abdomen. Okay, this is easy, but it's usually reserved for MIBG scan. I mean, is reserved for cases in which for extra adrenal cases of tumors. Okay, like here, for example, whenever the pheochromocytoma or the neuroendocrine tumor is outside the adrenal gland, we call it paraganglioma. Like here, this is another MIBG whole body scan showing, you see, there is concentration of the MIBG here in this area. Okay, and here is the area of the urinary bladder, and this is of course the liver, you see, and this is the thyroid, this is the parotid gland and the submandibular salivary glands. All right, but here the most concentration they can measure where it is concentrated more. The most concentration of MIBG is in the right paramedian mid-abdomen. Okay, so is it clear? Are the imaging is the imaging clear of pheochromocytoma? Any problems?
No problem, doctor.
All right. So regarding treatment, actually treatment of resistant hypertension is with intravenous infusion of nitroprusside. It's an arteriolar and venous dilator, and you give it in a dose of 0.25 to 0.5 micrograms per kilogram per minute. Okay. And the maximum dose should not exceed 8 to 10 micrograms per kilogram per minute. The good thing about nitroprusside is that it has a short duration of action, less than 5 minutes. So if hypotension occurs, it can be easily reversed by temporarily discontinuing the infusion, as simple as that, right? The aim is to reduce the diastolic pressure to around 100 millimeters mercury. And the systolic blood pressure should be dropped by not more than 25%. Yeah, don't bring it suddenly from the very high to 120 to 120. No, you should decrease it by not more than 25%. Okay. And mind you, the use of sodium nitroprusside should be brief because of the possibility of cyanide toxicity. Okay. But there are also oral choices like nifedipine or labetalol. We don't have labetalol here in Egypt, as far as I know. And once the patient is stabilized, you give oral phenoxybenzamine 10 milligrams twice daily, okay? And you titrate the dose according to the blood pressure. Of course, you can give beta blockers like propranolol to optimize the patient for surgery. And if pheochromocytoma is suspected as the underlying cause of the hypertensive crisis, the treatment choice should be intravenous alpha blockers like phentolamine, 1 to 5 milligrams, repeated every 15 minutes as required, of course, by monitoring the blood pressure, or phenoxybenzamine, 1 milligram per kilogram infused over at least 2 hours. Okay? And of course, you can give a beta blocker, but in that case, you have to give it always after giving the alpha blocker to prevent unopposed alpha-mediated vasoconstriction, which may worsen the hypertension. Okay, so first give the alpha blocker and then if tachycardia is there and you still need to further control the blood pressure, you may add a beta blocker, right? And as I mentioned, an alternative would be sodium nitroprusside. The initial infusion of 0.3 micrograms per kilogram per minute, with dose increase every 5 minutes, titrating according to the blood pressure response. But of course, there is the danger of severe hypotension, so the patient needs to be closely monitored. And of course, in order to avoid or to prevent, to reduce cyanide toxicity, which is an extremely rare complication of sodium nitroprusside, you can infuse hydroxycobalamin 25 milligrams per hour, right? And once the blood pressure is controlled, the definitive treatment is surgery. Usually it controls the blood pressure in about 75% of cases. Of course, the earlier the case is diagnosed, the better the blood pressure controlled after surgery, because if the patient is diagnosed early, their vascular remodeling wouldn't have happened yet, right? But the more you wait, the more vascular remodeling will occur, all right? Usually the identification of patients with hypertension secondary to pheochromocytoma is difficult, okay? But if the patient shows the classic triad that I have mentioned of headache, palpitations, and sweating in the presence of hypertension, it has usually a high specificity and sensitivity for diagnosing pheochromocytoma, okay? But unfortunately, this will not prevent all cases of crisis, as not all patients with pheochromocytoma have symptoms or signs, like I mentioned, right? So finally, my take-home message to all of you is that endocrine emergencies are relatively uncommon. However, they are important disorders which all physicians encounter in the emergency department. And although many endocrine emergencies occur in patients with underlying endocrine pathology, it is important not to miss the diagnosis in de novo presentations, like the patient with acute hypocalcemia, okay? Or like cases of myxedema coma who present initially with myxedema coma. And the clinical diagnosis should never be missed, as delay can lead to worsened morbidity and mortality, right? Thank you very much. Any problems? Anything you want to ask about?
No, thank you, doctor.
Okay, so before
No, thank you,
leaving,
doctor.
thank you for the heart, Dr. Asma. Before leaving, I want you please to fill out a survey that I'm going to put in the chat of Microsoft Teams, in the chat, okay? It's a Google form again. Can you still see my screen? Can you still see my screen?
Yes, doctor.
Yes, doctor.
I will share the questionnaire with you. It's very simple. Where is it? Yes, this one. Yes. Yes, you see? Can you see the questions? Can you see the questions?
Yes, doctor.
Yes, the timing of the session was appropriate. The duration of the session was appropriate. The session was well organized. The content of the session was very clear. The instructor was well prepared. There was adequate time for asking questions. What did you like most about today's session? What would you like to change in this session? Okay, I need all of you, please, to answer. Can you see the link? I have 18 of you are still with me. So I need 18 responses, please. Here you see nobody has answered, so the responses are 0. Once you start answering, the responses will start counting, all right? You see, like here, okay? Of course, feel free to say whatever you like, because I'm not able to see who said what, but I need to have the 18 responses, please, okay? And those of you who filled the questionnaire, please remain online because I'm going to read out the answers for you, because everybody knows what he or she wrote, but it's always nice to know what other people think as well. All right? Yalla, 3 responses. Yalla, 15 more to go. Can you still see the slides? I mean the survey? Did all of you manage to reach the link of the Google form?
Yes, doctor.
All right. All right.
On my side, I'm still trying to do it.
Yeah, were you able to access the link? Could you reach the link?
Not yet.
Okay, never mind. I will put the link on the WhatsApp group. 1 minute. Let me put it there. It's on the WhatsApp group, Dr. Ed. Okay? So
Okay, thank you.
You're welcome. Come on, the rest of you. 9 responses. Okay. Great. Yalla. How many? How many are there? Yes, okay. Okay. 11. Yalla. Yalla. Hurry up, please. Hurry up. It doesn't take all that time. One more to go. One more to go, I think. Yes. Okay. All right. Thank you very much. So the timing of the session was appropriate. 60, almost 67% strongly agree, 27% agree, and how many percent? 6.3% strongly disagree. The duration of the session was appropriate. 56% strongly agree, 31% agree, 6.3%, this is 1, neutral, and 1 strongly disagrees. The session was well organized, 81% strongly agree, 1 or 6.3% agrees, and 6.3% strongly disagree, and 6.3% neutral. The content of the session was very clear, 81% strongly agree, again 6.3% agree, 6.3% strongly disagree, and 6.3% neutral. The instructor was well prepared, 87.5% strongly agree, 6.3% agree, and 6.3% strongly disagree. أنا أعترض إذا أنا موجود. There was adequate time for asking questions. 87.5% strongly agree, 6.3% agree, 6.3% strongly disagree again. What did you like most about today's session? Instructor's way to simplify information. Everything was clear and very informative. Nice to hear, extremely informative, everything. Doctor's illustration was to the point and clear. The instructor was very good, well organized, concise, and to the point. The way the doctor was explaining the session is very good to clarify the information. The content of the lecture was very informative. الشرح ممتاز جدا وسلس ومنظم و to the point. Thank you. Important subject. Yes, very important. The different imaging slides and the comprehensive review of the different systems. Good explanation, very clear and informative, full English speaking, clear, well-organized information. What would you like to change in this session? Nothing, 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 nothing. Shorter time or dividing this session? Yeah, I'm afraid I don't have the option of dividing the session. Maybe I will do that in the revision sessions, because the revision sessions are usually very long, because I'm going to revise most of the topics in terms of clinical features and imaging, because imaging is important for you as physicians and for the exam as well. All right. Please upload the PowerPoint and the record. The PowerPoint is already uploaded on Moodle in the postgraduate lectures. I will do my best to upload the recording, but you can access the video recording after we finish the meeting. You access the link again and then go to the chat. You will find recording. Beside it, you will find 3 dots. If you click on these 3 dots, it will open another window where you have to log in with your official email at alexmed.edu.eg, and then you can view the video recording or even download. All right? Case discussion of the lecture will be optimum. No, I assume nothing. If the duration of the session can be shorter, ولا حاجة, increase case studies based on discussion. Nothing in particular, nothing. It was perfect. All right. So I thank you very much for your interaction and for your patience today with me during the lecture. I hope it was informative, and I hope to see you, inshallah, in the revision sessions. As I mentioned, the revision sessions are going to be the very last sessions before the exam. Okay, so I need to know when exactly your exam is, because I'm going to hold them online as well. So I would like to have 2 or 3 revision sessions if possible, because they are really long. If I cover all the topics, pituitary, thyroid, parathyroid, adrenals, and so on, it's going to take a lot of time, particularly revising the imaging. It's going to be very long. So you tell me when it would be suitable for you. All right? Okay?
Okay, doctor.
Thank you very much.
Okay,
I
thank
wish
so much,
you,
Doctor.
you're most welcome. I wish you a pleasant evening and happy learning. Assalamu
Thank you,
alaikum wa rahmatullahi wa barakatuh.
Thank you, doctor.
You're welcome.